Hello and welcome to a special interview for The Wire. What is the true picture of the spread of COVID-19 in India, and what are the key steps the government now needs to take? Those are two fundamental questions I shall put today to the President of the Public Health Foundation of India and a member of the WHO's Executive Committee handling the Solidarity Trials, Srinath Reddy. Professor Reddy, as of 9 o'clock today, Saturday the 6th of June, India has over 236,000 cases, which means we are nearly 3 times China, and we've already overtaken Italy. In addition, the Hindustan Times says that the daily cases and deaths calculated on a weekly basis have increased every single week for the last 10 weeks. And as a result, today, India is number 6 in terms of overall cases, but in terms of new cases, we're third. And people look at these figures and get rather worried. They ask the question, is India losing the fight against coronavirus? What's your answer?
Well, I would like to say two things first. These numbers are worrying and they certainly call for action. But we must also look at it as an opportunity to do better, because numbers which are based without taking into account the population size do not give the true picture. So if you actually take the cases per million or deaths per million, we are much lower than many other countries. This is not to be complacent. It is only to say that there's much to be gained in terms of protection. There are large areas of this country, the rural areas, much of Eastern India other than Calcutta, who have been very lightly touched or untouched. Therefore, it is very important for us to prevent the virus spreading fast and contain the damage. Therefore, if you only look at the numbers without taking into account the population size, it is alarming. It is certainly a call for action, no reason for complacency. But I think it is also a call for protecting the vast segments of our population who are still unaffected, and therein lies an opportunity.
Okay. Now, as you know, Professor Reddy, the initial aim of the lockdown was to flatten the curve. That certainly hasn't happened, though some people say it's not growing as steeply as had been feared. What would you say are the gains from the lockdown?
Well, I think firstly, we did actually have some success in slowing down the spread of the virus, at least in the initial stages of the lockdown, the first 2 stages of the lockdown. It also gave an opportunity for the health system to prepare a little better in terms of increasing its resources, in terms of personal protection equipment, getting more ventilators into place, but also getting the systems a little better geared up for testing, which was initially at a low ebb. It also gave some opportunity for some of the social protection measures also to come in terms of protecting the people who are isolated, in terms of providing them some social benefits. But that was, again, a very patchy affair. Some states did that very well. Some states have not done that very well. It also brought in a little better administrative coordination and consultation between the center and the states. So there have been some gains, even in terms of public health, as well as in terms of the overall response. But it is absolutely important for us to recognize that we may have lost some of those gains in the last few weeks, and we must actually move ahead to consolidate the gains and ensure that the vast areas that are still unaffected are protected, while vigorously containing it where the virus is already well established.
Let me bring up one particular gain that the government announced on the 22nd of May when they made public the result of several mathematical models that had been done. These claimed, and I'm underlining that word claimed, that perhaps as many as 2.9 million cases had been averted, perhaps 78,000 deaths had been prevented. But Dr. Randeep Guleria, the director of AIIMS, has said to me that this is just rough guesswork. And Professor Gautam Menon, one of India's most renowned disease modelers, says he simply doesn't know what to make of these figures because the government hasn't revealed the assumptions on which the modeling was done. So how do you, as an expert yourself, view the claim that perhaps as many as 2.9 million cases and 78,000 deaths have been averted. How seriously do you take this claim?
I would not actually take the claim on cases seriously because of the simple reason that the criteria for performing the tests, identifying who are eligible for being tested, has varied over this period. Also, the testing methods have varied. The number of testing laboratories bringing in the private sector with their own patterns of testing, all of that has varied over this time. Therefore, for us to actually look at the case numbers, I think it would be very fallacious. On the other hand, deaths, even if undercounted, do show a trend. You can look at the trend in terms of deaths per million and then say, okay, this is the number of deaths that has been happening week by week or fortnight by fortnight, and then say, okay, if the original pattern had continued in an exponential rate, then this might have been the number of deaths that might have occurred, and this is possibly the number of deaths that could have been prevented. We cannot actually attribute it only to the lockdown. There have been several other containment measures that have been undertaken. Contact tracing, for example, bringing in social distancing and masks, for example. All of these have happened. I do not think you can have attribution only to the lockdown, but to the whole package of containment. I think at least in terms of deaths, even if undercounted, the trend can be measured, and I think there has been some element of success in that.
Let me pick you up on that, Professor Reddy. You say that the claim about deaths, 78,000 deaths, is more credible than the claim about cases. But some of the modeling has been done by the Boston Consultancy Group. And frankly, I don't know how much expertise they have either in public health or in disease modeling. But the upper range of claim put out by the Boston Consultancy Group about deaths was that perhaps as many as 2.1 lakh deaths have been averted. And if you calculate in terms of India's mortality rate of 2.8%, that suggests that to avert 2.1 lakh deaths, you would have had to avert 7.5 million cases. Does all of that sound credible, or do you think the Boston Consultancy Group end of this range is becoming close to fictional?
Well, they will have to provide a difference of their estimates and their methodology. But you can see that among the cluster of estimates that were provided that day, I think there was a broader consensus that the number of deaths prevented range somewhere between 55 to 78,000. So that was a closer range. But I would certainly not go with the higher range estimates because I believe they are a bit off the mark.
A bit off the mark. That is beautifully put, sir. Let me put to you a second issue of concern. As I said, India already has 236,000 cases. The precise figure as of 9 o'clock this morning is 236,657. Yet the government keeps insisting repeatedly that we haven't entered the community transmission stage. And many people find that very hard to believe. Do you accept that we can have nearly 250,000 cases and not have entered community transmission?
Well, I suppose it depends upon who is actually defining what community transmission is. I think from the governmental spokesperson's point of view, they are dealing with several bushfires rather than a wild forest fire at this point in time. And therefore, they feel that these are local spreads, very markedly so, but nevertheless not widespread across the country. But I'm not going to argue with this semantics. My point is we have to take into account the fact that we are actually seeing a rise in number of cases, even if they are now segregated to some areas. But the warning is that this could actually spread across the country, and we must take all the measures possible to contain it, slow it down as much as possible, and certainly in the hot containment zones to put down the fire as quickly as possible. But I would not actually spend a lot of time in contesting the semantics. I would believe that we must act as though we are dealing with a community transmission, which is bound to happen in any country with this kind of a problem, as it has happened in all the other countries which have faced a problem of this magnitude. It is for us to move forward and plan as though we want to put down the number of cases, particularly in those areas which are protected, but in those areas which are already quite badly affected, we need to act vigorously as well.
In that answer, Professor Reddy, you said that there is a real danger that the infection could spread across the country. That's what I want to take up with you now. We know that in the last few weeks, tens of millions of migrant workers have gone back to villages in rural Bengal, UP, Bihar, Orissa, Telangana, Chhattisgarh, Jharkhand. Not only are they carrying the virus with them, but several newspaper reports suggest that they may have a positivity rate that is double, sometimes in some sections triple the national average. Are you worried that we could now see a surge in the rural hinterlands where they've gone back?
Well, the national average represents some of the hot containment zones in the urban areas. Therefore, some of these people would have higher prevalence than in the rural areas, possibly. I have always maintained that they should have been assisted in going back right at the start of the lockdown, because at that point in time, they would not have been exposed to the foreign return travelers or their immediate contacts by the nature of their occupation or their dwellings. Having put them up in the cities for almost 2 months, we did expose them to the virus. Even then, the positivity rate in them is not likely to be much higher than in the general population, particularly even if you are taking an urban population. Now we know that the positivity rate in the population is somewhere about 3 to 4% maximum. So I do not think that we can really think that every single migrant who is returning home is likely to be a virus carrier. I think that would be an unfair assumption. But secondly, all the precautions must be taken for quarantining them as close to home as possible, doing syndromic surveillance for symptoms, and testing them at the earliest opportunity. So I think we need to ensure that our villages are protected. But if we actually treat the returning migrants as a threat to the villages and advertise it as so, that will only build up a stigma against them, even from their rural communities. And that is a danger that we must avoid at any cost.
I understand that completely, but if there is a spread of the virus in rural India as these migrants go back, and logically one would expect there would be, do we have sufficient COVID hospitals and COVID healthcare centers in rural India? Do we have proper effective testing mechanisms in rural India? Because that's where we might need them. Do they exist there?
Unfortunately, that is again very patchy across the country. There are some states which can actually handle it better, particularly the southern states and possibly even Odisha. We know that much of the other states in the north and even the northeast for that matter cannot really handle it if the magnitude of the infections rises, whether in terms of testing or in terms of actual hospitalization. We only have to hope that at the moment, the ingress of the virus into rural areas from urban populations is extremely limited, that the people who are returning can be quarantined effectively and tested as much as possible, and therefore the spread of the virus in the rural areas is going to be limited. Let me also point out one more fact. What is called the R0, the number of people who are infected by a particular virus, differs according to the mobility in the population where they are in. In urban areas, the mobility is much more and the R0 is much more because people move around a lot and meet many more people. In rural areas, the R0 is much less. Therefore, the spread of infection to that extent is much less. Therefore, these are some advantageous factors in rural areas that we must certainly use to our benefit in containment. But I think the neglect of primary healthcare services as well as district hospitals in the past is coming to haunt us. And that is something we must really ensure we can repair. Also, as you rightly pointed out, many of these areas do not have adequate facilities. Only a health system which is functioning very well in the steady state can rapidly build up a surge capacity. Unfortunately, we have had an under-resourced health system, both in terms of financial and health workforce resources. And therefore, some of the states who have not invested adequately are now finding it difficult. Whereas some of the southern states who have done well in building up stronger health systems, not necessarily the steadiest, but fairly strong, are doing much better.
Okay. Let me then ask you this. When do you expect the peak? There are some people who say it could be June, July. I'm not sure whether they hold to that any longer, but that was said. That was Randeep Guleria himself who said it. Others say August, September. What's your hunch?
Well, we are looking at so-called peak in terms of the number of cases. And we are also recognizing that our tests have been increasing of late quite substantially, but there's still, even those who are tested on the basis of symptoms, there are a number of people who are asymptomatic and infected, as we are finding out from the rest of the world. And even in India, we are recognizing that many of the people who are tested positive are also asymptomatic, which means the number of people actually infected would be much larger than the number of cases. Therefore, for us to actually plot a curve based on just the testing numbers would be inappropriate. I'd rather look at the rate at which the deaths are progressing. If we can actually keep the rate of rise in deaths well under control, and particularly if we feel that in our country, the case fatality rate, or better still, the infection fatality rate is low of the people infected, then we can actually get a much better appreciation of the picture. But
Then
even more.
Can I interrupt? If you prefer to look at peaks in terms of the rate of deaths rather than the rate of cases, when do you think we'll have the peak in terms of deaths? Or is it just impossible to say?
Well, if you take the total number of deaths, then it's bound to rise because it's a cumulative number. I would like to look at deaths per week and then see if that rate actually keeps falling steadily over a month. And then I would say at least the infection is under control, because there's a lag period of 7 to 14 days.
At the moment, as the Hindustan Times has calculated, deaths per week are rising. They've been rising every week for the last 10 weeks, which means the curve of the deaths is going up. We're nowhere near the peak at the moment.
Yes, that is. We must also recognize there's a backlog of about 7 to 14 days between the symptom onset and deaths. So we are really looking, if we are looking at deaths today, we are looking at the infections of about 7 to 14 days ago. But I would still like to look at deaths, because that's ultimately what matters in the epidemic. How many lives we are saving, rather than just the number of cases who are infected.
But then you're also saying, Professor Reddy, that at the moment, A, we are nowhere near the peak because the number of deaths per week is steadily rising. And secondly, we don't know when it will start tapering off. So it's a bit of a, forgive my language, mug's game to start predicting when we hit the peak. It's not worth doing. When we know we've hit it, we've hit it. Let's not spend time predicting when that will happen.
Entirely agreed. I mean, some optimistic predictions have been made in the past, more on hope than on the basis of realistic estimates, because there were so many imponderables at that time that people could not take into account. And the level of success in containment due to the different stages of lockdown also was not very certain. The level of physical distancing was not certain. But I think if we keep tracking the deaths and then ensuring that rate comes down, then at least we can be fairly confident that we have actually turned the corner.
Let me at this point, Professor Reddy, put to you 3 or 4 statistics that the government regularly at their press conferences makes a point of emphasizing, because they believe they bring comfort and reassurance. And I want to ask you one by one just how comforting these statistics are, or are they in a way just meaningless? The first is the recovery rate. India's recovery rate is just marginally above 48%, but I noticed that Italy, with over 33,000 deaths, has a recovery rate of 70%. Spain, with over 27,000 deaths, has a recovery rate of 69%. So clearly, you can have a very good and high recovery rate and a very worrying number of deaths at the same time. The two don't preclude each other. So how much confidence can we in India take from the fact we have a 48% recovery rate?
Well, I think the recovery rate is a bit of a misguiding number, because you're calculating the recovery on the basis of the cases that have been diagnosed in the past several days, but they might not have completed the clinical course. Some of them may be just a few days old in terms of actually in their clinical course. So after a few more days, they may actually recover. So we know that most of the people with COVID-19 will eventually recover. So it depends upon the time of the epidemic and when you are actually counting the recovery rate. Therefore, in Italy, where the epidemic numbers hit a peak much earlier, the recovery comes earlier. I'd rather look at the closed cases. Even among these numbers, I would look at the closed cases and then see out of them how many have died and how many have recovered, because then you are actually declaring closure. You don't declare recovery when a person is still on the convalescent mode.
I'll come to the mortality rate in a moment's time, but let me first bring up a second statistic that the government constantly keeps talking about. This time we're talking of the doubling rate. Now, India's doubling rate is said to be 15 days, but I see that the United Kingdom and the United States have a doubling rate of 35 days. Italy has 55, Spain 56. So, and these are countries with a huge number of deaths. And their doubling rate is considerably better than ours, sometimes by a factor of 2 or 3. So again, how much confidence can we in India take from a 15-day doubling rate?
Well, I think a doubling rate is useful only in the initial stages of the epidemic, when you are looking for an exponential case count rise. And then say, okay, how fast is it doubling in terms of numbers, and can we slow it down? But as the actual base count keeps rising, obviously the doubling time increases. For a count to go from 5,000 to 10,000 takes a certain number of days. But for it to go from 50,000 to 100,000, obviously it's going to take a longer time. That's why you're going to see the United States having a very high doubling time, because they have had actually a very large number of cases and large number of deaths, and it takes a while for that to double. Therefore, I believe that depending on the doubling time, except in the very early stages, is a very incorrect appreciation of the picture.
You've made perfectly clear, Professor Reddy, that the emphasis the government puts both on the recovery rate as well as on the doubling rate is a bit mistaken. It's giving confidence where perhaps people don't quite understand what nature of confidence is being given. Let me then come to a third factor that the government emphasizes. That is the mortality rate. India's is 2.8. The global average is said to be 6.13. But I noticed from Worldometers that there are over 100 countries whose mortality rate is even lower than India's. And some of those 100 countries, at least 2 or 3, are in the top 20. So once again, I ask, how much confidence can we take from a 2.8% mortality rate?
See, unfortunately, the mortality rate is being estimated in different ways. The usual figure that is being used is case fatality rate, which is a fairly incorrect figure to use for the simple reason that the denominator consists of the number of cases who have been diagnosed and the numerator consists of the number of deaths. Now, the more tests you do, your denominator is going to expand, even if your testing criteria don't change. But quite often, if your tests increase rapidly, then you're more likely to get some of the milder cases included in the denominator, whereas the number of deaths in the numerator remains fairly small. So the more tests you perform, you're likely to get a lower case fatality rate by simply expanding the denominator. That's what the United States is doing. I mean, they're putting in a large number of numbers. They're putting what are called viral tests. They're putting in antibody tests. They're putting repeat tests, all of them in the denominator, and saying, okay, our CFR is pretty good compared to other countries. That is actually not a particularly useful way of looking at things. But let me mention also.
Can I interrupt? You've given a good explanation why America's mortality rate is, so to use the word, fudged, because they are building up the denominator to make the figure look low. Would that also apply to India? This steady decline in the mortality rate, is it a reflection of the fact that the number of tests is increasing, therefore the denominator is increasing, and therefore the rate is falling?
Yeah, we also have to recognize one more fallacy of the CFR. CFR varies not only between diseases, but also between age groups. The older people have higher CFR than the younger person in the younger age group. Therefore, it's useful to compare diseases at the end of the epidemic period or different age groups or different hospitals, but not to track the death rates across the population. Certainly, whether we are actually seeing the CFR fall because of an increasing number of tests, that's a possibility. But let me just read out a little statistic for you, which is essentially that our death rates and our test rates and our case count rates have generally increased almost at the same level. But I would say that I would rather go by deaths per million any day rather than depend upon the CFR, because I don't think CFR is a very good indicator.
Finally, and once again, before I come to the last statistic, once again, although you haven't in any way rubbished the confidence the government puts in the mortality rate, you have raised questions about the way it's calculated and the way, as a result, it seems to be steadily declining. Let's leave it there. Let me come then finally to something that gives the health minister great confidence, because these are hospital statistics that he's quoted. He said that, in fact, only something like 6.4% of Indian cases get to hospital, less than 3% get to ICU, less than 0.5% require ventilator support compared to an alleged global average of 3%. And as a result, the health minister told the Economic Times on the 23rd of May, the virus is not that virulent. Do you accept this critical point, that these hospital statistics prove that the virus in India is not that virulent?
Well, actually, case fatality rate is useful to find out the virulence of the virus when you're comparing it with other viruses, and particularly if you compare it with something like MERS or SARS or even some other virus like Ebola. Certainly, this is a virus that doesn't kill as many. But the question is it different in our population? Maybe because of the age structure, maybe because of other reasons where there is a certain amount of immunity. But I was only criticizing case fatality rate as a measure. But if you take deaths per million across the country, we are only at 4.7 deaths per million compared to many countries in Europe and even the United States, which are about 300 or 400 deaths per million. So to that extent, I think we have actually experienced far fewer deaths. Whether it is because large segment of our population have not yet been exposed to the virus, or whether it is also because even those exposed are likely to get milder infections and not die, I think it's both. But I think it sends two lessons. First is we can be reasonably hopeful that the virus is not going to kill as many in India, taking into account the population size as the denominator, as it has done in Western Europe or in North America. But also it means that there are large segments of our population potentially at risk who need to be protected, and that is the call for action.
But just to be absolutely clear, do you believe that these statistics, the recovery rate, the mortality rate, the doubling rate, and the hospital statistics that I quoted, do you believe all of them suggest that the virus is not as virulent, or are they better explained by the fact that we have a very young population, 90% of whom are under 60, many of whom will not get affected, or if they do, they'll be very mildly affected and they quickly recover? Which explanation is better? That the virus is not that virulent and therefore we are experiencing a different strain, or that our strength is the age profile of our population?
Well, as far as the virus strain being different, we do not have a very clear-cut evidence, apart from some minor mutations. Is it behaving differently because of only the age structure? Possibly. For that, we need age-standardized mortality rates. We need to look at what is happening in each decade of age and calculate the mortality rates there and see how they compare. Are the 70-plus population in India behaving in the same way as the 70-plus population in Belgium? Is the 60-plus population in India behaving the same way as the 60-plus population in Italy? That's the comparison. However, there are also other potential reasons why our innate immunity, conditioned by many other exposure to infections, we do not know yet about BCG, polio, and others, they're all hypothetical. It is possible that our ability to combat the virus, even if its virulence is not altered, may be better than some other populations. We are seeing this in a number of other Asian populations. It's not just India. Most of South Asia is experiencing that. Most of Southeast Asia is experiencing that. Therefore, it's not just a question of India alone. It's possible that there could be multiple other factors, many of the unknowns in this maze of unknowns.
That's beautifully put. What you said is that you are not convinced that these statistics prove that the virus is less virulent. What you're suggesting is that there are multiple other factors that would explain why we are not dying in the same numbers as people died in Europe and America. One factor is the age profile, we're a younger country. The other could be what you call the innate immunity because of BCG or polio. And as you pointed out, this would be true not just of India, but of our neighbors in Asia and as well as many countries in Southeast Asia. Let me end part one by putting to you one last statistic, but this time it's a statistic that's going the other way. I'm talking of the positivity rate. It was said to be 4.9%, but now, if you look at the number of people found positive divided by the number of people being tested over the last 10, 12, 14 days, that rate has moved up from 4.9 to 6.41. How much of a concern is that?
Well, it depends also upon the testing criteria. Certainly, if you are relaxing the testing criteria, you would expect the positivity rate to go down. But initially, of course, you also had a large number of contacts and returning foreign travelers being tested who may not have necessarily harbored the virus but were being checked as a precautionary measure. If the positivity rate with the same criteria and particularly standardized for the number of tests being performed, if that starts rising week by week, either it means that we are improving our criteria for testing and strategically testing better, or that the infectivity rate has increased, or possibly both.
Okay. The second, of course, would be much more worrying, but we don't know whether it is the second. Let's not speculate. I'm going to take a quick break at that point. When I come back, Professor Reddy, I want to turn to the second big question that I want to put to you. What are the key steps the government needs to take now? But first, a little break. Welcome back to a special interview for The Wire. My guest is the President of the Public Health Foundation of India and a member of the WHO's Executive Committee looking after the Solidarity Trials, Srinath Reddy. Professor Reddy, let's come to the measures the government needs to take. First, as of 9 o'clock this morning, Saturday the 6th, the ICMR's website says that India has done roughly 4.5 million tests. Yesterday, we did nearly 138,000. Now, in absolute terms, that sounds like a lot, but actually it's just 3,281 per million compared to 86,000 in Spain and 68,000 in Italy. Do we therefore need to ramp up testing in a very dramatic, big way?
Well, the testing has to be directed based on certain criteria, and all the people who meet that criteria need to be tested. So if you're saying that people who are having typical symptoms of COVID are now extended to influenza-like illness, or healthcare workers or other frontline workers who are at a high risk of exposure, or family contacts who are at a high risk of exposure, then they do need to be tested. But we can't go around testing haphazardly anybody on the street, on the ground, that they could be asymptomatic virus carriers. So we have to have clear-cut criteria and test according to those criteria in adequate numbers.
But you know, you're putting stress on the need for clear-cut criteria, but the Delhi government has just in fact reduced the criteria. Now, if you have been in contact with a person who's found to be COVID positive, but you are not symptomatic yourself, you won't be tested. Earlier, you would have been. Is it wise at this point for the Delhi government to be making the criteria more stringent and reducing the number of people who would qualify for testing?
I think that that would not be a right approach, because at least during the period of full lockdown, even if the family contacts were actually exposed to the virus, they too, along with the person infected initially, would have been contained within their home till the period of the lockdown was over. So to that extent, they too would have actually, whether symptomatic or asymptomatic, actually expelled the virus from their body during that 3-week period. But now that we are opening up, not to test close family contacts with a high risk of repetitive exposure to the virus would not be a right policy.
Now, on Thursday, it was announced by the ICMR that they are doing a major serological sentinel survey that will cover 69 of India's 739 districts. The problem is that's less than 10% of the districts. Should this survey not be done nationwide rather than be limited to less than 10% of districts?
Well, I suppose they're going to start with 64 districts, as you said, and then extend it to others as well. But also remember that there is also a syndromic surveillance that's being done by the National Center for Disease Control. And we cannot only depend upon testing alone as a strategy. The testing with antibodies essentially tells you what the likely spread of the virus in that population is. But if you are also looking at people who are actually experiencing symptoms and who need to be tested for viral presence for containment, especially when the lockdown is being relaxed, then you have to actually have household syndromic surveillance. And that is being done in some of the southern states where people are actually being visited every week in their house and then being asked whether some of the symptoms of influenza-like illness, which overlap with that of COVID, and some COVID-specific symptoms are reported by anybody in the house. And if so, then the medical team visits them and then tests them. So unless we do this kind of syndromic surveillance, we'll not be picking up the cases who need testing even according to the criteria.
But you know, it's very interesting. You mentioned the need for household syndromic surveillance, but only 3 or 4 days ago, Professor Gautam Menon, one of India's most renowned disease modelers, points out that critical information that is necessary, critical data for modeling, is actually being withheld. He said, for instance, details of the number of people visiting hospitals with influenza-like symptoms, which previously the NCDC would make available on a weekly basis, have been withheld since February. You're talking of a syndromic surveillance to cover something very similar, but information that's with the NCDC, which is now critical, has been withheld since February. It should have been made available rather than choked off. Isn't that contradictory?
Well, I think all agencies who have data, after screening and sifting the data, should make it available for analysis, both by competent government agencies as well as independent agencies who can observe what the trends are. But I think we need not depend only on some of these agencies that you have mentioned. Many of the states are doing it on their own. I think if we can have the state data available, and particularly it's very important that we have district level analysis. You cannot just have a national analysis. We have to have decentralized appraisals of how the virus is actually spreading in the community. And therefore, we actually need the state level data to be made available for detailed analysis.
One last question. Professor Gautam Menon, who works with several other scientists, there's a whole group of 300 or 400 of them, have done their own modeling, and they believe that perhaps as many as 10 million people are undetected but infected, and they're in the community. Does that worry you? Or would you say to yourself, these are likely to be asymptomatic and therefore not as much of a cause of concern as they might have been 2-3 months ago?
Well, I have not looked at the nature of his modeling, but I do respect his ability to do good modeling. So I would say that if we have large numbers who are undetected, asymptomatic, firstly, it's a good sign that this virus is not killing or even making people very sick in large numbers. Secondly, it's all the more important for us to recognize that many of these people cannot be hunted down by testing. Where how do you actually grab a person on the street and find out whether the person is actually an asymptomatic or a pre-symptomatic virus carrier? Which emphasizes again the need for other measures like physical distancing to the extent possible, masks and hand washing. Now it has been estimated that just masks and hand washing, even if physical distancing is difficult, can actually cut down virus transmission by 60%. So these are the kind of things that we must ensure that everybody practices, even as the governmental agencies have to have stronger containment measures. I think all of these need to go hand in hand.
I take your point entirely. All I'll point out for the sake of the audience is hand washing in slums where you don't have tap and running water is really very difficult. It's not something the government has ever addressed. The Prime Minister talks about the need to wash your hands regularly, but if you don't have running water, you can't wash your hands. But let me come to my last question.
Let me answer that. I fully agree with you. But if you can have water mafias running water tankers across the country, and trying to, particularly in cities, and trying to extract a lot of money. Can't we actually commandeer those services and make sure that blankets are available in slums? I think we have to use the governmental power.
What a delightfully Italian response. If the mafia can do it, so can the government commandeer the mafia services. I think that's a beautiful response. Let me end by putting this to you. At many stages in this interview, you've emphasized the importance of the mortality rate. How confident are we that we are accurately reporting deaths? Or are there some deaths that may be clearly a result of COVID, but are not being accounted for as COVID deaths? We know, for instance, that in Delhi, the municipal corporations have recorded almost 2 or 3 times the number of COVID positive burials and cremations compared to what the Delhi government admits are COVID deaths. I'm sure that's happened in several other cities as well. And I know also in rural India, there may not be an effective way of ascribing a cause for a death. So are we accurately estimating the mortality rate? Because that has been critical in many stages of your answers.
Well, I agree. It is possible that we are undercounting the deaths partly because of underreporting of COVID cases, typically, or even misclassification by attributing to other causes. In hospitals, at least, we should be able to get fairly clear-cut data, hopefully. But out-of-hospital deaths are more difficult for us to get it. And even for in-hospital deaths, I would suggest that we actually do a verbal autopsy technique as a follow-up, and particularly for out-of-hospital deaths, which means that the household where the death has occurred can be visited by fairly empathetic community workers or primary healthcare workers with a simple questionnaire as to what were the symptoms that preceded the death and what was the nature of illness. And that can actually tell you with some level of confidence, which can be validated against proven cases, that what is the likelihood of a particular person having died of COVID. And therefore, we may be able to get a better measure of the number of deaths. Having said that, assuming that there is misclassification, underreporting, even if we think it's a 3-fold undercounting, still the number of deaths in India would still be much lower than many other countries. That is a comforting factor, but that is not necessarily a factor for us to only count the deaths as they are being counted now. We certainly ought to do much better in that direction as well.
That is a very reassuring, and even if we are undercounting by a factor of 3, the number of deaths in India are still a lot less than other countries, and therefore the mortality rate, whether it's accurately reported or underreported, continues to be one statistic that does reassure and comfort. That is a positive note on which to end. Thank you very much for talking to me, Professor Reddy. Stay safe and take care.
Thank you very much. Thanks.
To receive instant updates on all videos from The Wire, click the subscribe button and hit the bell icon. Pay to support independent journalism. Click the link in the description and choose the amount you want to pay.